Any question from the audience?
Okay, there.
Not here.
Let's see if everything is sorted out.
Sandro, thank you so much for addressing my question in your talk. Thank you, really. One question. Let's say you have 10,000 patients, so power is not a problem. You find 1% difference. That is support the claim of low prognosis, or 3% or 5%? Actually, I'm asking you as a clinician with a lot of experience, what is for you the threshold that defines a patient as low prognosis? I saw your elegant demonstration of that. POSEIDON indeed show a low prognosis, but as a clinician, what is the threshold? And thank you again for answering my question.
Thank you very much, Juan. Well, I think if I look into the data, I would say that it has to be 30% and above. As a clinician, I think if I have a difference of 20%, I will consider significant in terms of that particular outcome, for this outcome. So if you go for, others think that cumulative delivery rate could be very hard to obtain the data because it will take a long time to get this information. And I see other groups of investigators looking to other metrics, even using the POSEIDON classification, like ongoing pregnancy rate and also live birth rate per transfer. So I think that in that regard, we won't be able to see this difference so, exacerbated as we have there. My patients, I think if I have this 20% reduction, that's something that I will be concerned. And obviously, the discussion is, as you pointed out nicely, it is how low is low, and it's quite clear that not all patients can be put in the same box. For some patients, some couples, young patient population like group 3, in which they have low aneuploidy risk, they might accept this reduction of 30% that we showed, 25 to 30%, because they won't be able to get more oocytes. But this communication with the patient will be, in my opinion, a more transparent way to provide an estimate. And the other things that I feel important is that some doctors come to me and say, well, I think the patient might be very stressed when we provide such outputs like this information and also the art calculator that sometimes can be shocking, the number of oocytes. But we found in our clinical experience that this conversation is quite productive for the patient perspective, because when the cycle fails, for me, it's easier to discuss with my patient that we had that discussion before, rather than the patient think that my laboratory is bad and the doctor is not good, and then they move to another clinic. So I think it's painful somehow, when obviously the patient is classified. No one wants to be classified as poor in anything or low in anything. But this is something that I believe as a clinician has helped me to manage my patients more efficiently.
Any other question? Thank you.
Thank you very much, both speakers. Excellent presentations. I have two questions to actually both of you regarding the prevalence of the POSEIDON groups in the overall population. So 40% is the number that you published. Intuitively, do you agree that it's a bit strange to see the proportion of POSEIDON 1 and 2 to be relatively high in centers that we all assume are fully aware of already the importance of the number of oocytes and the right dose setting, the right product using. So this hyporesponder group is fairly high. Just would like to have your comments, what you think explains that. And also why you think that the group with reduced ovarian reserve, POSEIDON 3 and 4, is altogether fairly low, together only 20%, which is again going against maybe what many people think, that we have many more patients or cycles with real reduced, from patients with reduced ovarian reserve. So I would like to have your insights there and what you think explains that. And the second question I have is on the non-POSEIDON group, if you have data, how many of these 60% had normal responder patients and hyper-responder patients, to find a differentiation between the two, if you have the data to make a comment on that.
Okay. Thank you very much, Thomas. Well, I will start with the last one, with the non-POSEIDON patients. All non-POSEIDON patients, they got more than 9 oocytes. So in that particular group, we didn't look into, because we didn't classify patients as hyper-responders, suboptimal responders, based on the criteria of 4 to 9. So all of them got more than 9. So, I mean, we could look into that particular population to see FOI, the FOI. That could be very interesting, because then you can see, even in the normal responder population, now I have more than 9 oocytes, but let's see FOI or FORT. That could be very informative. Concerning the prevalence, I think it's a very interesting question. First of all, I was surprised when we got the results that the groups 1 and 2 were so significant compared to groups 3 and 4. So this is data that, I mean, is there. And this data, actually, in the prevalence study, we used AFC as the criteria to calculate the prevalence rates. Well, AFC of 5 is more, in my opinion, more strict than AMH of 1.2. So I believe that, I mean, that some variation could be related to the marker that we have used to classify, although the agreement study was competitive. And the other point that I want to stress is that when we say groups 1 and 2 hyper-responder, really? I mean, I'm sure that there are hyper-responders there. I mean, let's say if you consider low FORT or low FOI. But now consider a patient in which the AFC is consistent with adequate ovarian reserve according to POSEIDON. Let's say that I have a patient now with AFC of 8. So, and then this patient got 7 oocytes. Well, this is POSEIDON, if she's above 35, she's POSEIDON group 2. B. But is she a hyper-responder? No, I mean, the ovarian reserve was already exploited. So, I mean, this is another thing that we need to differentiate in these groups 1 and 2, because, I mean, there's a broad range of patients above the AFC of 5 and 1.2 that could also make this prevalence, I mean, the interpretation has to be with caution for us to understand exactly what we are analyzing.
Thank you.
Another question?
Yes. Coming back, thank you to both of you, but coming back to the concept of number of oocyte and age. Also this morning there was a nice introduction regarding the ovarian sensitivity, okay? If we look at your data, the group 3, the group 3 was the young one with the low ovarian reserve that really finally performed well, because the number of embryos developed were in line with so the number of oocytes retrieved were in line with intrafollicular count. And then if you see, they are above in terms of a chance to get pregnant above the number 2, the group 2. It means, for me, looking at this data, that age is more important than number of oocytes. But probably we are speaking indeed about quality. So number of oocytes and quality together. So it would be very interesting if we can get some insight how in this group of patients the quality due to age is getting is increasing the chance of pregnancy in respect of number oocyte of the group 2 that get more oocyte, but they are part of the older patient. So how you can comment again the relationship between number oocyte and age, that in your data demonstrated age is more important than number oocyte?
Thank you, Monica. I think this is a very interesting point that I have an answer based on the data set. So when I compare the cumulative delivery rate, as you pointed out, in group 3 versus group 2 as a whole, so group 3, because they are the younger patient population, they performed better. But when I split group 2 between 2A and 2B, now is different because group 2B cumulative delivery rates in the pairwise comparisons, the p-value was not different. So in the data set, it shows that increasing the oocyte number, group 2B, older patient population was able to offset the equation and make the cumulative delivery rate similar, not statistically different than group 3. And now group 2A, above 35, with up to 4 oocytes, and then the problem was there. So if I go directly and answer your question, I would say, well, its number of eggs seems to have an important factor. If there's something else in group 3 that could be explored, as discussed in the morning, what are the infertility factors there? I'm sure we need to evaluate to get some more insights.
Any other question from the audience? Okay, just to conclude, I have just one question for you, Professor Esteves. You told us that the BMA is very represented in POSEIDON groups. Can you develop further this part? In which group this aspect is more prevalent?
I think you showed that.
I mean, when you do the logistic regression analysis, both, to identify as an independent predictor of the POSEIDON state, group 3 and 4 when combined in group 1 and 2, and compared to the non-POSEIDON counterparts, BMI is a significant predictor.
So the BMI is just worsened in all POSEIDON. Okay.
Yeah, we found an association because in retrospective data analysis like that, we cannot, as Hakam pointed out, make any causal relationship. So what we found is that the relevant covariate in the POSEIDON affecting either the prevalence study and the cumulative delivery rate was BMI. The POSEIDON patients overall, and also in groups 1 and 2, 3 and 4, they were slightly heavier than non-POSEIDON patients. So it seems that perhaps the BMI is affecting somehow the ovarian response in POSEIDON's group 1 and 2. I believe so, because the prevalence of POSEIDON groups 1 and 2 in this study was quite significant. Perhaps we need to look into more detail the issue of BMI. We had just the video stressing the importance of lifestyle and controlling weight, and we all know that it's important when we calculate our gonadotropin dose for stimulation. So I think that we need to look into that. When we go for the coefficient that we found in the regression analysis to provide you an estimate, like every unit of BMI will make the patient more prone to be in the POSEIDON group, we have that data, so we don't see a major increase, but it was significant that BMI showed up in all analysis we did.
Thank you.
So I think we can end this session. Thank you very much to the speakers and to all the participants in this session. We are not finishing yet because I have to call Professor Carlo Alvigi, who will close the first day of this conference. Thank you very much.
Thank you, Alessandra.
to propose some concluding remarks, but we are more than half an hour over time, so I think that we will conclude everything tomorrow at the end. What I would like to say now is just that I was so happy to see so much participation, discussions, and it is very important because, as I mentioned this morning, Poseidon is an open community, and we hope and we need that this community will grow. So I strongly invite you to go to the website. Tomorrow we will show the way for even hypothesizing to have delegates and representatives in different countries for Poseidon. That I think is very important for coordinating next initiatives. The only thing I would like to say as a concluding remarks is that when Poseidon was born, the idea was not having only something useful for designing trials, proposing criteria stratification, but something that could be in the pocket of the doctors in the daily practice. Because Bologna criteria are very good, but yes, we can design a trial defining the primary endpoints, which is the best endpoints, delivery rate, and whatever. But when you dialogue with the patient during your counseling, you don't have a Bologna criteria in your pocket to give some decision or providing tools. So Poseidon is a suggestion for a practical approach, introducing new markers, FOI, introducing a system for calculating the number of eggs, introducing tools, and the hope for the future is also finding a way for suggesting a good matching from patients and protocols, considering that the groups of Poseidon are different in terms of pathogenesis and prognosis. So I think that it was the main message that we have from today's session. Practical use of Poseidon and the idea that Poseidon is, in my opinion, good validation about the idea that is able to differentiate among different subgroups of patients. So thank you so much for your participation and collaboration, and I do hope that these sessions improved all of us for patient taking care.